دي
لحظة
بتتشال
واحدة بس يا
ازاي؟
سمير. بسم الله الرحمن الرحيم. Welcome in this new meeting of Egyptian Society of Nephrology and Transplantation, CME chapter meetings. And this new meeting, I am really pleasured to have my dear friend, Professor Samir Kamal, Associate Professor of Nephrology and Medicine in Acute University and the head of Nephrology Dialysis Unit in Acute University, as the speaker in this session. Professor Samir, he is well known for his CME activities in Acute as regarding his annual courses, CME courses and conference that is held yearly about 5 years ago, or 7 years ago. This was the seventh one, and especially with his workshops that precedes his annual conference. Many workshops, interactive and acting to deliver the scientific message in our South Egypt. So I am really pleasure to have him now as the speaker in this session. And our topic today is one of the important topics in critical care nephrology and AKI. And because of this, I am with you today in this session as the moderator. We will speak about sepsis-associated acute kidney injury. Before we go to the lecture, as usual, and come after the lecture in the discussion, I would like to welcome all our attending Professor Shan Sayed, President-elect of Egyptian Society of Nephrology and Transplantation, Professor Saeed Khamis, Professor of Nephrology and Medicine in Menofia University and the ESNT board member. And I would like to thank Dr. Mu'tasim Al-Sayed, lecturer of nephrology and medicine in Mansoura University and Mansoura Nephrology Center, and one of the very active members of CME chapter in Egyptian Society of Nephrology and Transplantation, for all of his work in CME chapter and being the coordinator of this session. Please, Professor Samir, start your lecture, which I expect to be a great one as usual, and I will come again for this discussion, which I expect to be a heavy and very scientific one. Thank you. Start, please, Professor Samir.
بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. Many thanks, Professor Yasser Abdel Hamid, for this very kind introduction. As usual, you are my best friend, and I should welcome to all our professors. The talk today is very simple, very basic, and the discussion will be with our experienced professors, because there is a lot of debates in this issue. أنت سامعني يا دكتور ياسر؟
سامعك كويس. صوتك
okay.
واضح. صوتك واضح.
Okay. Let us talk about acute kidney injury in ICU as a major topic, with a special emphasis on the sepsis-associated acute kidney injury. السلايدز مش بتتحرك دكتور ياسر. معتصم،
تتحرك. حركها كده، اتفضل.
انا بحركها مش بتتحرك. هي كانت بتتحرك من شويه.
Yes, it is not moving here. مش بتتحرك نفسه.
Start, please. Start, please.
Okay, again, welcome to all. Acute kidney injury is a real global burden. As you all know, that global burden of acute kidney injury-related mortality exceeds by far that of the breast cancer, heart failure, and diabetes. So it is a very important subject to anticipate and to monitor acute kidney injury, especially in ICU patients. The epidemiology of acute kidney injury in ICU, a lot of studies with heterogeneous results, from 30 to 60% of admissions to the intensive care unit the mortality rates may exceed 50%. This meta-analysis, multi-center, multinational study with more than 1,800 patients from 97 intensive care units, they reporting that acute kidney injury of any stage developed within 1 week of admission in 57% of patients. Severe stages 2 or 3 in acute kidney injury occur in about 39%, and 13.5% require renal replacement therapy. Acute kidney injury survivors are more likely to develop significant morbidity, especially chronic kidney disease after acute kidney injury episode. The etiology of acute kidney injury in ICU is different in high-income countries compared with low and middle-income countries. In high-income countries, it is most prevalent in older patients in the context of multi-organ failure, with higher mortality. Hypotension and shock are the main causes, but in low and middle-income countries, it occurs mostly as a complication of a single disease, with mortality rates about 21%, and around 77% of them is community-acquired, and dehydration being the most common cause. This is the definition of acute kidney injury. You all know these criteria for diagnosing acute kidney injury according to whatever your stratification system, either KDIGO, acute kidney injury, or rifle criteria. I have to highlight on that urine output is very important as an indicator for acute kidney injury, but it is not of significance in hepatorenal syndrome. Otherwise, any acute kidney injury in ICU, urine output is a major criteria for diagnosis. If it is decreased below 0.5 milli per kg per hour for 6 to 12 hours, the patient diagnosed as acute kidney injury. Then the serum creatinine increasing 0.3 or so and so. You are all known these figures by heart. What about acute kidney disease compared with acute kidney injury? Acute kidney injury, deterioration of the kidney function from hours to days up to 7 days. May be extended beyond 7 days. That's now called acute kidney disease. This multi-center study, about 5,334 patients admitted to ICU who were assessed for de novo kidney injury, followed by about 1,600 days follow-up. They reporting that 1 in 4 ICU patients with de novo kidney injury met acute kidney disease criteria. So acute kidney injury, after 7 days, it extends. These patients had an increased risk of short-term mortality and long-term major adverse kidney events. Patients with acute kidney disease during their ICU stay should be identified to initiate interventions to reduce the risk of future MICs. These are the criteria for defining kidney diseases: either acute kidney injury up to 7 days, acute kidney disease from 7 days to less than 3 months. After 3 months, chronic kidney disease, and non-kidney disease. There is no functional or structural criteria. The difference between acute kidney injury and acute kidney disease is the presence of structural criteria that is present usually in the acute kidney disease. So acute kidney injury, if it is extended beyond 7 days, usually associated with elevated markers of kidney damage. Mortality is increasing if the patient develop acute kidney injury. As you see, the whole total acute kidney injury in patient in the ICU compared with non-acute kidney injury, the mortality is high. In stage 1, to some extent, the patient with stage 1 acute kidney injury compared with non-acute kidney injury comparable, but the more the stage development of acute kidney injury, the more the mortality to the patients. Now there is a proposed new definitions for acute kidney injury. The stages, we know the stages of acute kidney injury, stage 1, 2, and 3, but now these further classified into stage 1A and B, stage 2A and B, stage 3A and B, according to the presence of damage criteria or biomarkers. If in stage 1 associated with damage criteria or biomarker positive, this is stage 1B. And stage 1 is if there is no change in the serum creatinine is normal, but the patient developed a structural damage to the kidney by a biomarker. This is called a stage 1S acute kidney injury. We have to stratify the patient of acute kidney injury. It is important to determine which patients are at higher risk for progression to acute kidney injury, so can allow for closer monitoring and earlier intervention. As you all know, that's creatinine, increased serum creatinine is beyond the damage of the kidney. If it is increased, the damage of the kidney is massive. So we always know anything to detect or to anticipate the presence of acute kidney injury before starting increase of the serum creatinine. We have a clinical risk stratification in the ICU. This clinical risk scoring developed in 2017 with 21 points. If the patient has chronic kidney disease, it have 2 points, chronic liver disease, 2 points, congestive heart failure, 2 points, hypertension, atherosclerotic coronary vascular disease. And if the patient is acidotic, 3 points, nephrotoxic exposure, 3 points, severe infection or sepsis, 2 points, mechanically ventilated, 2 points, and if the patient is anemic, 1 point. The more the score is increasing, the more the prevalence of this patient is in a higher risk to develop acute kidney injury. This clinical risk stratification, this can help clinician to stratify patient for primary prevention, surveillance, and early therapeutic intervention. Also, clinically, we have furosemide stress test. This test to stratify patient at intermediate risk of acute kidney injury progression. If the patient develop acute kidney injury, stage 1, and you wanted to know if this patient in a higher risk to progress to stage 2 and 3, you can give the patient intravenous furosemide 1 milligram per kg if the patient naive, or 1.5 milligram per kg if the patient previously exposed to diuretic therapy, and you will collect urine in the next 2 hours. If it is below 200 milli over the next 2 hours, this patient has a very high risk to progress to stage 2 and 3. It has 87% sensitivity and 84% specificity to predict progression to stage 3 acute kidney injury. Also, the venous congestion. Venous congestion, if it is present to the patient in the ICU, this patient is in a higher risk to develop acute kidney injury and in a higher risk for mortality. The congestion regarding the portal congestion, the venous congestion, the intrarenal veins, or hepatic congestion detected by Doppler. If the patient is congested, the mortality is higher, while not significantly associated with mix at 30 days. This condition does not signify the mortality or major adverse kidney outcome at 13 days, but Doppler abnormalities suggestive of venous congestion were associated with higher mortality in critically ill patient with severe acute kidney injury. Obesity. Also, the obese patient in the ICU are higher risk to develop sepsis-induced acute kidney injury. In critically ill patient with sepsis, those with higher body mass index had a higher risk to develop early sepsis-associated acute kidney injury. Also, there is computer algorithm. With the development of AI, there is a lot of computer algorithms. This by machine learning algorithms have been used to identify patients at higher risk to develop acute kidney injury or for requiring renal replacement therapy. These complicated models can predict acute kidney injury with greater precision than that risk prediction scores. And this can be used in real time to screen for acute kidney injury in the ICU and have been shown to detect acute kidney injury up to 6 hours earlier than the laboratory markers. The importance of this algorithm is dynamic, because this regarding the timing of acute kidney injury, the changes that occur to the patient during monitoring, so the predilection model can update the risk stratification for the patient in the ICU. Also, there is online risk stratification. These two validated online applications for predicting the risk of acute kidney disease and its prognostic mortality in critically ill and elderly patient, with the top 10 predictors are creatinine on day 3, presence of sepsis, delta blood urea nitrogen, diastolic blood pressure, heart rate, delta creatinine, creatinine on day 1, respiratory rate, and pH, and diabetes. These also very validated two online applications for risk prediction for acute kidney injury in critically ill patients. Creatinine, as you all know, that is not a real-time marker for acute kidney injury. Creatinine may gradually accumulate in the acute kidney injury that may lead to delay in recognizing both the onset and the resolution of acute kidney injury. Serum creatinine is also influenced by creatinine generation, volume of distribution, excretion. Also, we recognize the effect of age, gender, nutritional status, and certain medications. Particularly in critical care settings, attention must be paid to the impact of low muscle mass on creatinine generation. Urine output itself is not an inadequate marker of clearance, leading to wider utilization of urinary creatinine clearance measurements. How about biomarkers? A lot of serum and urinary biomarkers may help the differentiation of acute kidney injury owing to intrinsic kidney damage from that owing to hemodynamic changes. They can also potentially be used for finer phenotyping of the cause of kidney damage. But actually, the novel acute kidney injury biomarkers have the potential to add useful prognostic information. However, it is important to use these biomarkers in the appropriate clinical context. Indiscriminate use may cause sensitivity and specificity to decrease significantly. And the only applied biomarker is NGAL in the context of hepatorenal syndrome. And the optimal biomarkers or the panel for biomarkers has not yet been developed, but it is an area of active research and study. There are risk factors of acute kidney injury in the ICU. There is non-modifiable patient factor include age more than 65, genetic factors, baseline comorbidities, including pre-existing renal disease, heart failure, liver disease, previous acute kidney injury, and diabetes. Emergency of cardiovascular surgery also elevate the risk. And there is modifiable risk factors include hypovolemia, urinary tract obstruction, shock, sepsis, rhabdomyolysis, exposure to agents interfering with renal autoregulation. As you all know, acute kidney injury is not a limited renal disease. This is a systematic disease from the start because there is a distant organ effect on the brain, on the lung, on the liver, on the intestine, on the bone, and on the heart. So the mortality is increasing, the systemic affection is increasing, especially if the patient is sepsis. Sepsis is a multisystemic disease, and acute kidney injury is a major complication of sepsis, and it will add more and more systemic effect. The cause of acute kidney injury is well known, but the cause of acute kidney injury in ICU are surgery, ischemia, comorbidities, cardiorenal, chronic kidney disease, mechanical ventilation, acute lung injury, sepsis, decreased immune function, renal perfusion, decreased drug metabolism. You will find that sepsis is in the core for the development of ICU-associated acute kidney injury because it alters the immune function, and the altered immune function will lead to sepsis. It leads to acute lung injury, and the acute lung injury is sepsis-induced acute kidney injury, and it leads to mechanical ventilation. Mechanical ventilation will add another cause for acute kidney injury. You will find that sepsis can contribute to about 50% of the causes of acute kidney injury in ICU. And this is a common cause of acute kidney injury in ICU. You will find that sepsis and shocks in the top 50% of acute kidney injury cases in the ICU, the incidence about 10 to 20% of the septic patients, overall 50 to 70% in septic shock. Other common causes are cardiac surgery, intra-abdominal hypertension, cardiorenal syndrome, acute liver failure, hepatorenal syndrome, and malignancy. The general management of acute kidney injury in critically ill patient, first you have to anticipate the risk or the patient at risk to develop acute kidney injury and discontinue all nephrotoxic agent when possible. Ensure volume status and perfusion pressure. Consider functional hemodynamic monitoring. Monitor serum creatinine and urine output. Avoid hyperglycemia and consider alternative to radiocontrast procedure. If the patient develop acute kidney injury in stage 1, you will have start diagnostic workup, either non-invasive or invasive. And if the patient develop advanced stage 2 and 3, you will more and more closer and you will think about another modality for treatment. Sepsis-associated acute kidney injury is common increasing prevalence problem in ICU, but actually, fortunately, the most patient with sepsis-associated acute kidney injury has stage 1 acute kidney injury, and the recovery is more or less better. The pathophysiology of sepsis-associated acute kidney injury is recently changed. It is not a matter of ischemia or simple type of ischemic injury. It is a complex mechanism started by hyperinflammation, which is stimulus triggered by the sepsis injury and characterized by humoral and cellular mediator, which exacerbate the renal injury. The immune cellular infiltration followed by organ failure. The presence of PAMPs and DAMPs interact with tubular injured cells, and these DAMPs and PAMPs interact with proximal tubular epithelial cells, with the result of reactive oxygen species production and apoptosis and cell cycle arrest. As you will see, the inflammatory mediators, DAMPs and PAMPs, damage associated and pathogenic associated molecular pattern, it filtered in the glomerular filtrate, and it will be on contact with the proximal tubular cells. In the proximal tubular cell, it initiates pro-inflammatory and microenvironment in the tubular cell and on the near vascular part to the proximal epithelial cells with rarification of this vascular part. With paracrine stimulation and epithelial cell triggering, with oxidative stress in segment 2 and 3, with tubular epithelial cells. The end result is shedding of these cells and the development of tubular toxicity and acute kidney injury. Sepsis-associated acute kidney injury management is 2 golden rule in the management. Timely administration of antibiotics and source control, appropriate volume resuscitation. This is 2 golden rule in the management of sepsis-associated acute kidney injury. The patient in septic shock, you have to know that not that more than one type of shock can coexist in a given patient. The patient entered the ICU with sepsis, developed septic shock, it associated with hypovolemic shock, and may be complicated with cardiogenic shock. And if the patient entered with hypovolemia and dehydration, patient may catch hospital-acquired infection and then develop septic shock and may complicated by cardiogenic shock. Each type of shock is different from the other, but they are present together. We have to know that in the distributive or the septic shock, the central venous pressure preload is decreased and the systemic vascular resistance is markedly decreased. But in hypovolemia, the preload is more and more decreased, but the systemic vascular resistance is increased. This is important in the management and in the choice of the vasopressor or the use of inotropes in the management of this shock. So we have to decide if the shock stage of this patient is just septic shock or it is associated with hypovolemic shock or the patient developed cardiogenic shock on top. Treating shock is treating the underlying cause with combination of intravenous fluid and or vasoactive mediators. fluid administration in shock was traditionally guided by BOCUS, point-of-care ultrasound, and invasive hemodynamic monitoring, CVP, and pulmonary artery occlusion pressure. We no more need for pulmonary artery wedge pressure because a series of RCTs showed no overall benefit. The use increase for significant catheter related morbidity from infection, arrhythmia, pulmonary artery rupture. So we can rely on the central venous pressure and point-of-care ultrasound in assessing the volume status of the critically ill patient, saving the pulmonary artery wedge pressure for severe pulmonary hypertension and right ventricular failure patients. The choice of the vasoactive agents is very important because we have in septic shock, we have the vascular resistance is increased. So we have to choose the vasoconstrictors, either norepinephrine or high-dose epinephrine or high-dose dopamine or low-dose epinephrine and dopamine to ensure the improvement of the septic shock. And if the patient is associated with hypovolemic shock, the volume status should be monitored in a very dynamic process. This is the fluid status of the patient. The patient may in need for volume repletion in the first, then the patient may in need for the use of diuretic if the patient become hypervolemic. So this is not a single measurement for the volume status. The volume status should be continuously monitored, and in critical illness associated with progressive decrease in the kidney function, lower odds of renal recovery, and increased mortality due to venous congestion, which can lead to renal venous hypertension, increased renal interstitial pressure, and ultimately reduced renal blood flow and glomerular filtration rate. So the registration of the volume status should be on the time. Fluid therapy may be beneficial, may be harmful according to the volume status. The diuretic therapy may be increased, may be decreased accordingly. The prevention, some hints about other causes of acute kidney injury in ICU. In the cardiac surgery, the use of renal protective fluids, balanced crystalloid solution, and avoid of starch solution have been shown in studies to reduce rates of acute kidney injury, minimizing the CBP time, and using off-bypass technique are associated with reduced cardiac associated acute kidney injury, or post-CABG acute kidney injury. The mainstay of this kind of acute kidney injury is prevention. When prevention fails, treatment is just supportive. In the acute respiratory distress syndrome, the cornerstone to address the underlying cause while providing lung protective mechanical ventilation, low tidal volume lung protective ventilation protocol reduced absolute mortality by 9% in the large randomized control trial. Careful management of fluid balance. There was a trend for the less renal replacement therapy need with the conservative strategy. The renal replacement therapy in ICU patients, the debate, past and present. As you all know, that dialysis is not a safe procedure. Dialysis may be associated with end organ damage. Dialysis-related factors such as intradialytic hypotension, altered oxygen supply, electrolyte flux, osmotic shift, biocompatibility reactions, thermal imbalance, uremic milieu, nutritional losses. All these may add to the critically ill patient and may deteriorate the patient. So the need of renal replacement therapy should be applied in the right direction and on the right time, on the right patient. How to manage sepsis-related acute kidney injury or acute kidney injury in ICU patient with renal replacement therapy. Preemptive renal replacement therapy is not of benefit by a lot of randomized control trials and early versus late initiation of renal replacement therapy. The 2012 KDIGO acute kidney injury guidelines suggest initiation of renal replacement therapy in the patient with urgent indications such as severe acidosis, severe hyperkalemia, and acute lung edema. However, the initiation of renal replacement therapy must find several obstacles related to the unstable hemodynamic phase of septic patient. In addition, delays in renal replacement therapy could compromise acid-base electrolytes and fluid balance, causing more severe complications of acute kidney injury. These are the timeline for initiation of renal replacement therapy, either early or late initiation of renal replacement therapy. We should have to know what is early and what is late. These studies randomized controlled trials, multi-center, except the first one in 2002 and the second in 2013. This is a single center study, but we have to know that early means the 6 to 12 hours after developing of stage 2 acute kidney injury. And late means after 48 hours of developing acute kidney injury. The end result between early initiation or late initiation in the Bowman's et al., no difference in mortality. In the Jamil et al. In 2013, earlier did not improve survival, delayed the recovery of kidney function. And Alien et al., early strategy showed low 90 days mortality. And AKI 1 and AKI 2, no difference between strategies at 60 days mortality, and the ideal ICU, no difference between strategies at 90 days mortality. So these are the major studies for the early versus late initiation of renal replacement therapy. If we ignore the first one because single center study, we'll find that the difference in mortality is no difference, and the other key outcome also of not significant. And these are the changes in the early initiation: more dialysis dependent at 19 days, a higher overall renal complications, and catheter-related bloodstream infection is higher. And the late initiation carries the diuresis occurred earlier, and more hyperkalemia may occur to these patients. So early versus late, the benefit of an early renal replacement therapy start was not provided. But not to be very late, because this study ensures that more late than 72 hours carrying a high rate of mortality. This multi-center study from 39 ICUs in France, with the conclusion: in severe acute kidney injury patient with oliguria for more than 72 hours, or blood urea nitrogen more than 112, and no severe complications that would mandate immediate renal replacement therapy, additional delay in renal replacement therapy initiation did not confer additional benefit and was associated with a potential harm. So don't delay beyond 72 hours after developing of stage 2 acute kidney injury or oliguria, or blood urea nitrogen more than 112 milligram per deciliter, even there is no urgent indication for dialysis. Continuous renal replacement therapy versus intermittent renal replacement therapy. Currently, there is still controversy about the selection of treatment strategy for the treatment of patients with acute kidney injury in ICU. Identifying the best treatment modality is important to effectively improve patient outcomes and reduce the economic burden of social and families. Continuous versus intermittent. The major advantage of CRRT is the stable hemodynamics, because dehydration is slow, the incidence of hypotension and arrhythmia is low, and there is no renal ischemia. This is the advantage of intermittent versus continuous renal replacement therapy. As you see, the intermittent hemodialysis carry the advantages of rapid removal of toxins, low molecular weight substances, intermittent nature, facilities, scheduled investigations, procedures, and mobilization, can avoid use of anticoagulation with low cost and availability. with the disadvantage can lead to rapid shift in the osmolality, electrolytes, and fluid removal, can risk dialysis disequilibrium and cerebral edema, may have greater workload and re-exposure demand, and may be not available. No. This is CRRT. The CRRT is affords greater hemodynamic stability. Ultrafiltration can be modified in response to intake output, affording greater fluid balance control. Steady removal of metabolic waste can avoid risk of treatment-induced increased intracranial pressure, can allow sequential therapies for blood purification, and simple and user-friendly technology can be delivered by ICU nurses, with the disadvantage of slow clearance of toxins, general need for anticoagulation, implication of bleeding or metabolic complication related to anticoagulation, risk of electrolyte abnormalities, hypophosphatemia and hypokalemia, relative need for immobility, can have greater bedside workload or higher cost. The major reviews and meta-analysis between the choice of intermittent versus renal replacement therapy actually not conclusive. This one review was a conclusion that intermittent hemodialysis often exacerbate hemodynamic instability with higher rate of fluid and solute removal. This is another one with the conclusion is likely no difference in mortality between CRRT and intermittent hemodialysis. Also, CRRT may increase renal recovery compared with intermittent. This is another systematic review and meta-analysis, concluding the result that renal recovery, no significant difference in renal recovery, short-term mortality, no significant difference, and the length of ICU stay CRRT significantly shortened the length of ICU stay of patients compared with intermittent hemodialysis. The hospital stay CRRT significantly shortened. And this last one was from the START AKI trial, with the conclusion that retrospective analysis of START AKI trial in critically ill patient with severe AKI, initiation of CRRT as compared to intermittent hemodialysis was associated with significant reduction in the composite outcome of the deaths of dialysis dependence at 19 days. Another one with the conclusion CRRT, when administered to the right patient at the right time, the benefit of CRRT are unassailable. So continuous kidney replacement therapy and survival in children and young adults, finding from the multinational We-ROC collaborative, survival was not detected to be associated with variation in dialysis mode, dose, catheter size, and location, and anticoagulation. So there is no conclusion that one is better than the other. Still, the KDIGO 2012, the use of CRRT and continuous and intermittent renal replacement therapy as a complementary therapy in patients with AKI is not graded. They suggest using CRRT rather than standard intermittent renal replacement therapy for hemodynamically unstable patients, and they suggest CRRT rather than intermittent for patients with acute kidney injury with acute brain injury or other cause of increased intracranial pressure or generalized brain edema. How about the BBMA-based continuous hemofiltration? This type of adsorptive process with hemofiltration, high absorptive properties in removal interleukin-6, interleukin-8, interleukin-1 beta, tumor necrosis factor alpha. This BMMA-based CVVH can efficiently modulate immunological dysfunction in sepsis-associated acute kidney injury. How about the prolonged intermittent renal replacement therapy? This is a very good modality. Prolonged intermittent renal replacement therapy is another RRT option in the ICU. Prolonged intermittent renal replacement therapy consists of treatment over 6 to 12 hours with blood and dialysate flow rates that higher than CRRT but lower than intermittent. It may replace CRRT or be used as a bridge between CRRT and intermittent hemodialysis. Combining HV, HF, and adsorptive membranes, hemoadsorption. How about the use of hemoperfusion? This is a set of hemoperfusion with a charcoal or sorbent-containing filter, and this is the commercially approved hemofiltered, with the conclusion of that it did not reduce the mortality at 28 days in sepsis-associated acute kidney injury. How about TPE? Therapeutic plasma exchange. This is debate also, significant debate over the risk-benefit of TPE in sepsis and MODS. Could this be a benefit in prothrombotic forms of sepsis? What parameters to follow? All are debate. This meta-analysis with the conclusion plasmapheresis may be an important adjuvant to conventional treatment to reduce mortality in patients with severe sepsis or septic shock. This another meta-analysis with the conclusion is insufficient evidence exists to recommend the plasma exchange as an adjunctive therapy for patients with sepsis or septic shock. Another good observation is post-acute kidney injury proteinuria. Post-acute kidney injury proteinuria is the level of proteinuria is valuable risk stratification tool in the post-acute kidney injury period. These results suggest there should be more widespread and routine quantification of proteinuria after hospitalization from acute kidney injury. Peritoneal dialysis is a good option in ICU. This publication concluding that in the management of dialysis requiring acute kidney injury in critically ill patients, peritoneal dialysis is comparable to SLED in the term of correction of metabolic and clinical derangements. The long-term outcome, high mortality within the first 2 months. A quarter of long-term survivors experienced worsening of the renal function. Renal replacement therapy initiation strategy was not associated with mortality outcome. Lastly, we have to anticipate renal replacement therapy, trying to prevent acute kidney injury, anticipate acute kidney injury and trying to prevent it. The follow-up is very important. The time of detection and the registration of the development, the monitoring of the patient is very important to be a good outcome for acute kidney injury. Thank you for your attention.
Thank you, dear Professor Samir, my dear friend, for this highly elegant and comprehensive lecture about sepsis-associated acute kidney injury. It is not really about only sepsis-associated acute kidney injury, but he started the lecture with global definition in general of acute kidney injury. What is acute kidney injury? Definitions and how to diagnose acute kidney injury, prognosis, and the impact of biomarkers, and even the importance of stress test, furosemide stress test in ICU in detecting the progression of acute kidney injury in ICU. And as I remember, when we are discussing and preparing for this lecture, Professor Samir stressed on the importance of this test, and he wants to illustrate the importance of this test for juniors. And yes, he did it in the first part of his lecture today. Then he started to go in deep through sepsis-associated acute kidney injury. What is the pathogenic mechanism and how can it go to the process of shock? And another important point is that shock is not single etiology. Multi-etiology can exist or can coexist in the process of shock, especially if we consider that the complication of shock includes all organs, affecting myocardium, affecting blood vessels. So we can find a cardiogenic shock in a vulnerable patient in addition to septic shock, which is a very important point. What's the pathogenesis? What is the etiologies and management of septic shock and shock in general? Fluid management, he summarized the fluid management, need of inotropics, when to use inotropics in case of there is associated cardiogenic shock, and vasopressors in cases of resistant septic shock. And coming into the importance for us as a nephrologist, importance of renal replacement therapy, initiation of renal replacement therapy, types of renal replacement therapy, and a comparison about the types of renal replacement therapy, which can we use. And I think the most important item is that we are to use them complementary as stated in KDIGO guidelines in complementary manner to reach the proper prognosis. Also, prognosis of AKI in ICU generally, I think it's 50% mortality, and which is so strange that this number did not change, always reaching around 50%, even with more advanced and even more and more advanced in science. AKI mortality in ICU remains ranging around 50%, this number. Thank you, Professor Samir.
Thank you.
Thank you for this lecture, and we can go to comments. Professor Saeed, please unmute yourself.
ألف شكر دكتور سمير، وشكرا لحضرتك دكتور ياسر. محاضرة رائعة كالعادة دكتور سمير، والله يعني
يا باشا بعد ما عندكم احنا بنتعلم
ربنا
من ساعتها.
يخليك. لا، حاجة جميلة جدا كعاداتكم يعني.
ثانك يو.
إذا سمحت لي يا دكتور ياسر دكتور سمير، بالنسبة لموضوع السبسس والسبسس انديوزد اي كي اي، أنا هتكلم للزملاء الأفاضل اللي هم الجينيورز أنا ليه بيبول فاشن شوية عشان أبسط الأمور.
اوكي.
الوقاية خير من العلاج زي ما بيقولوا،
طبعا.
يعني بمعنى آخر بريفنشن بيتر ذان كيور. ان انا بسيب العيان يدخل في سيبسيس، او بمعنى اخر الاسوأ ان انا بكون السبب ان يدخل في سيبسيس ياتروجينيكالي. ياتروجينيكالي في صوره ايه؟ استخدام ماني انفيزيف تكنيكس، وكان لسه الدكتور ياسر بينوه ليها قبل ما حضرتك تكون معانا يا دكتور سمير. unnecessarily بمعنى ايه؟ الاوفر انسيستيك انسيرشن اوف سي في بي لاين، وساعات العيان ما بيبقاش محتاج هذا السي في بي لاين اطلاقا.
صح.
اوكي، ده نمره واحد. نمره اتنين، بيتنسي خالص السي في بي لاين ده، ممكن العيان يروح بيه عادي جدا. ده انا بقولها اسقاط يعني، عفوا. نمره اتنين،
مش عايز اقطعك يا دكتور سعيد، هو المفروض اساسا في المانجمنت لو العيان developed stage 3 acute kidney injury you have to remove CVP.
yeah.
One of the general management is trying to remove central lines.
yes. second، اليورينري كاسترز. تلاقي مريض في
Very
الاي سي
important.
يو
Very good.
انوريك، واخد بال حضرتك، بيجيب بالعافيه 50 سي سي يورين، وانا قاعد تحت القسطره عمال اقول ايه ده جاب النهارده 70، ده جاب 75. اوكي، ايه لازمه القسطره في هذه الامور؟ احنا برضو يعني في المال براكتس بنستخدم اليورينري كاستر فريكوينتلي انسيسرلي. يبقى لو هعمل له حتى بلادر الترا ساوند اشوف اذا كان في يورين في ديلي في اليورينري بلادر ولا لا، ومش ضروري يورينري كاستر ان unnecessarily indication. دي نمره اثنين. نمره ثلاثه، بالنسبه لل abuse of antibiotics، هو اوكي it should be as early as possible، وما بين قوسين زي ما حضرتك قلت تكون نون نيفروتيك انتيبيوتيك، لو هدي امريك لحد ما الايه الكالتشرز تطلع. ودراسات كتيره اتعملت على التايمنج بتاع الانتيبيوتيك، بيحسبوها بالساعه من وجوده في الاي ار. اللي يتاخر اكتر من كام ساعه هيبقى ده ديلي في التريتمنت، والديلي ده هياثر على المورتاليتي والموربيديتي يعني بطريقه سيئه. وبالتالي الايرلي انيشيشن اوف انتيبيوتكس از فيري كروشال. طبعا ما بين قوسين تكون از ماتش از وي كان نون نيفروتوكسيك انتيبيوتيك لحين البلاك كالتشر نتيجتها ما
Culture
تطلع.
based.
وما نتخدعش في البلاك كالتشرز، لان 50% من البلاك كالتشرز بتطلع نيجاتيفز. So I should repeat at least within 12 hours at least twice this في البدايه موضوع البلاك كالتشر. الجزئيه اللي بعد كده بالنسبه للمانجمنت اوف سيبسيس، موضوع الاي في فلويدز. كلاهما سيء. الاوفر بيسموها فلويد اكيوميليشن سندروم او فلويد اوفر لود سندروم، او ان انا اسيب العيان فوليوم ديبليتد. ولو اخترنا منهم الاسوأ مين؟ الفلويد اوفرلود سندروم او الفلويد اكيوميليشن سندروم. على عكس ما احنا الايرلي جولد دايركت ثيرابي اللي كانت طلعت في فتره وقال لك لازم العيان قدر الامكان تديله كميات مريبه من الاي في فلويدز. الامور دي تراجعت الى حد كبير في السنين الاخيره، لان الهايبر فوليميا نفسها لها ديترمنتال افكت على الرينال كمان ان هي ممكن تعمل some sort of congestion، خصوصا في وجود الكارديو رينال لو كان العيان كاردياك زي ما حضرتك قلت، او تاثر بالسبسس ودخل في كارديو رينال او كده. وفي نفس الوقت هتعمل لي ما يسمى الرينال تامبونات زي على غرار الكاردياك تامبونات، فهيعمل some sort of congestion على الكدني، هتاثر سلبا على الكدني فانكشن. اخر نقطه بالنسبه للرينال ريبليسمنت ثيرابي، التشويس فيها اتزان ارت زي ما حضرتك قلت، والامر فيها ما هو دايما جري زون زي ما حضرتك عارف من فترات طويله زي ما هو ثابت على كده. والمورتاليتي ريت زي ما احنا عارفين في الاي كي اي عاليه، زي ما الدكتور ياسر نوه من شويه على غرار على ضوء حضرتك ما قلت. فمش عاوز الجينيور يمتغض ان الاي سي يو استدعوه الساعه 2 بالليل على كرياتينين قفز من 1 ل 2 ويقول له هو الكرياتينين بيموت. بيموت، مش بيموت دايركتلي، بس بيزود المورتاليتي بتاعت العيان. فالايرلي انترفنشن مهم. الرينال ريبليسمنت ثيرابي التايمنج بتاعه مهم، الرايت بيشنت زي ما حضرتك قلت مهم، الرايت تشويز للموداليتي اللي هستخدمها، وزي ما بيقولوا ايه بالبلدي اللي تغلب بيه العب بيه. والله الافوردبل عندك اشتغل بيه، وما تقعدش تقول ايه يا ده لو كان عندي البريزما او المالتي فيرتريت وعملت CRRT كان ده ترياق الحياه والعيان كان هيعدي. لا مش شرط ابدا، ما عندنا افري وير في العالم كله موجود هذا الامر، والنتائج كومبارابل زي ما حضرتك وضحت ما بين الانترميتنت، سواء بالذات البرولونجد انترميتنت او اللي بيسموها الCRRT. وبالتالي ما جلتش ذاتي قوي لو مش افوردبل عندي الCRRT وافوردبل عندي الكونفنشنال داياليسيس، ممكن استخدمه ببعض الموديفيكيشن ان انا استخدم البرولونجد انترميتنت الى حد كبير هيؤدي نفس الغرض. وزي ما كانوا بيقولوا عن البرولونجد انترميتنت قبل كده المسمى القديم اللي هو السليد، ان 11 ساعه من السليد تساوي 23 ساعه من CVH، فالى حد كبير كاوت كم كومبارابل. وبالتالي ما جلتش ذاتي لو ما عنديش CRRT. مره ثانيه زي ما الدكتور ياسر نوه قبل ما تبتدي المحاضره يا دكتور سمير، دو نو هارم، ان لم تنفع فلا تضر. فاحنا في الاتزان ارت ان انا امانج عيان AKI في الاي سي يو وما سيبش العيان يدخل في AKI او يدخل في السبسس، لان لو السبسس تمكن من العيان غالبا احنا بنفشل في الكنترول بعد كده، ما بنقدرش نعمل للعيان حاجه للاسف. وشكرا جزيلا ومعلش اسف في الاطاله.
لا بالعكس،
شكرا
انا بشكرك
شكرا
جدا على الهايلايتس اللي انت قلتها يا دكتور سعيد. وعايز بس اضيف لحاجه ان كل سنتر ICU لازم يكون عنده his own guideline for management of sepsis and eradication of sepsis. The antibiotic use، يمكن انا شايف حد من الساده الزملاء اللي موجودين بيقول ان enormous use of antibiotics very great، والناس كتيره بتكتب اي حاجه.
دي حقيقة.
ما ينفعش، لازم في الICU يبقى فيه بروتوكول، وكل سنتر يبقى ليه البروتوكول بتاعه في الانتيبيوتيك ريجيمن. انا هبتدي بايه بناء على ايه وبيزد على ايه، كالتشر بيزد. البايوفاير دلوقتي موجود، وات ايفر البيز اللي انت هتمشي عليه يبقى عندك ستاندرد بروتوكول
اللي هو
انت بتمشي
الانتيبيوتيك
عليه.
ستيوارد شيب يعني وكذلك نعظم من دور الكلينيكال فارماسيست. للاسف احنا ما بنعظمش دور لهؤلاء، ده الحاجات دي فات عليها عشرات السنين في اماكن اخرى يعني. فدور
بالظبط.
الكلينيكال فارماسيست مهم جدا زي ما حضرتك قلت.
بعد اذن
بالظبط.
حضراتكم يا دكتور سعيد، بس انا ليا نقطه. طبعا الكومنت بتاع حضرتك فيري كونسيدرابل، بس مش عايزين نخوف الناس من الانترفنشنز يعني
لا
هو
بالعكس بالعكس
السي في
بالعكس،
بيز واليورينري كاثيترز يعني في
very
عيان كريتيكال
important
ال.
زي ما احنا قلنا.
طبعا كريتيكال ال هنحتاجهم اكيد، يعني مثلا عيان بياخد
طبعا.
انوتروبكس، عيان هيخش على الريال ريبليسمنت
بس
ثيرابي
المبالغه فيهم
بروبر
مش
كير.
مطلوبه يا دكتور ياسر.
الايه؟ ما هو
المبالغه في
المبالغه طبعا،
استعمالهم
المبالغه في اي
unnecessary.
شيء مش مطلوبه، المبالغه في اي شيء
اه
بروبر فلو بالانس اتسترا. فيعني البروبر
اما
ده لا ينفي البروبر كير،
اكيد
ان هو ده
اكيد
المطلوب اكتر من ان هو يعني indicated، والبروبر
ايوه
كير is very essential.
شور.
في كويشن عن اللي اعتقد انت قلته، بس ما فيش مانع ان احنا ناكد عليه دكتور سمير، عن ال slow extended hemodialysis is better than CRRT or intermittent hemodialysis. انت قلتها يا دكتور سمير.
يعني عايز تختار ده ولا ده؟
هو بيقول ان هل هو بيتر عن الCRRT او الانترميتنت البرولونج انترميتنت
احنا
ريبليسمنت
قلناها.
او
بص،
السليت.
الموداليتي اوف دياليسيس صدقني مش هتفرق. انت متاح عندك ايه والبروفايل بتاع العيان ايه.
بالظبط.
طول ما العيان هيمودايناميكال ستيبل وما عندوش برين انجري، وانت الافيلابل عندك الانترميتنت، دو انترميتنت. والله انت شايف العيان هيمودايناميكالي كومبرومايز وما عندكش CRRT، وتقدر انك انت تشغله على الكونتينوس انترميتنت، ماشي، ويل اند جود. لكن انت عندك الفاسيلتي بتاعت CRRT والنيرسز اللي موجودين عندك ويل كواليفايد، والدنيا عندك كويسه، وما انتش خايف من الانتي كواجوليشن، والدنيا كويسه، جو اهيد وامشي باللي
هو ده
انت تفضله اكوردنج للفاسيلتي اللي موجوده عندك والبيشنت بروفايل اللي موجود قدامك.
وده
انما
الستيب اللي بتبتدي بيه.
الاوتكم مش فارق، زي ما انت شفت كل الميتا اناليسيس بتقول ان هو مش فارق قوي يعني.
وزي كده يجوا قالت ان الهيمودايناميكال انستيبل CRRT جو تو CRRT اللي هي 2012. احنا في انتظار بقى الجايد لاينز الجديده.
لو ده
ما اعتقدش هتختلف كتير يعني.
عندك عيان هيمودايناميك انستيبل وانت ما عندكش CRRT اصلا،
هتضطر تعمل طبعا سليد
هتعمل ايه؟
والاوت كم
هتعمل
مش
انترميتنت، كونتينوس انترميتنت، او
او
السليد بالمسمى
prolonged
القديم،
interval.
وات ايفر.
اوكي. شكرا. في سؤال من طبعا في ماني كونجراتيوليشنز دكتور محمد عبد الباري، دكتور رجاء رمضان، دكتور ريهام
ثانك يو فور
حسين،
اول.
كل دول استمتعوا جدا بالمحاضرة.
انا اللي
آه
استمتعت بوجودهم طبعا.
آه كومنت فروم دكتورة ملك نبيل: most cultures are MDR، ودي حقيقة.
دي
abuse of
للاسف
antibiotics
الشديد، للاسف
للأسف.
الشديد، علشان
للأسف.
الاستخدام السيء للانتيبيوتكس في عياداتنا، في
اه
العيانين اللي هم اوت بيشنت. انت بتكتب الانتيبيوتك لاي حاجه ولكل حاجه،
بالظبط.
وده بيخلي الدراج ريزيستنس عالي جدا.
ده بيتكتب دايناميك
يس.
توسلايتس يعني عادي دلوقتي.
لا لا. وهو
الافريزوليد يا دكتور، الافريزوليد يا دكتور سعيد، للاسف الشديد في الايرا اوف
بونبوني
بالظبط.
كوفيد كان بيتكتب لاي حد، اي حد معدي في الشارع ياخد افريزوليد.
وما زال
هو
يعملوا، ما زال
الام
ما
دي
زال
ار طبعا هو تبقى كوليستين، وده حل مش احنا ما بنحبوش ابدا بتوع الكلى. لكن في الحقيقه،
للاسف.
انا لاحظت بعد ما الناس كلها ابتدت زي ما حضرتك بتقول بيلجأوا بالذات الكينولونز ووجود الافريزوليد في الاخر، استعمالهم بقى امبيريكال على نطاق واسع. ابتدينا ما نستعملش الحاجات اللي هي البيزكس، اللي هي الامبيسيلينز
بالظبط
والحاجات اللي زي كده. دي
بالظبط.
ابتدت تظهر في الكالتشرز بقى دلوقتي. يعني
صح
تلاقي
ايوه، صح
كالتشرز
صح.
كتيره ابتدت تظهر
صح.
لك الاموكساسيلين كلافيرونيت،
دي حقيقة.
اموكساسيلين سالباكتم اتسترا. ده علشان ان احنا بطلنا استعمالهم امبيريكال على نطاق واسع.
الدوكسيسايكلين بدأ يظهر كتير
دوكسيسايكل بقى
جدا،
بيظهر كتير، دوكسيسايكل بقى بيظهر كتير
بس
حتى.
ربنا يستر الناس ما تبتديش تاخد بالها منه.
اه بالظبط كده. طيب، سؤال تاني عن سؤال من الدكتور احمد ياسين. انا مش عارف هو قصده الهايبرجلايسيميا، يمكن هايبوجلايسيميا افكت اون اي كي اي. يعني هو الاي كي اي كان كوز هايبوجلايسيميا. رايك ايه يا دكتور سمير؟ هايبرجلايسيميا ممكن تعملي طبعا اي كي اي.
الهايبرجلايسيميا طبعا هتفاسيليتيت الديفلوبمنت اوف اكيوت كدني انجري،
طب
وهتزود الانسيدنس اوف سيبسيس اسوشيتد.
هو عايز بيتكلم على الهايبوجلايسيميا. الهايبوجلايسيميا كان كوز اي كي اي.
الهايبوجلايسيميا تدخل في اكيوت كدني انجري؟ انا ما اعرفش.
انا فور مي اي دونت نو ممكن يكون الميكانيزم. يعني هي يس اكيوت كدني انجري كان بريسبيتيت هايبوجلايسيميا.
ماشي، لكن
لكن
الهايبوجلايسيميا
هايبوجلايسيميا
نفسها تدخل عام في اكيوت كدني انجري؟ اصل
لا.
الهايبوجلايسيميا اتس ماتر اوف مينيتس، لو ما
يس.
تعالجش العيان هيباس.
مش عارف. طيب، آه دكتور رياض سعيد موجود معانا. اتفضل دكتور رياض.
مساء الفل دكتور رياض.
لحظة واحدة بس اتأكد. دكتور رياض اتفضل، اميوت يور
موجود
سيلف.
يا دكتور إسلام.
اتفضل. اميوت يور
ايوه.
سيلف. اتفضل. اتفضل.
مساء الخير. مساء
اهلا
منور
الخير.
وسهلا.
الدنيا،
مساء النور.
منور
اهلا
الدنيا
وسهلا.
كلها يا دكتور رياض.
الله يخليك. استمتعنا يا دكتور سمير بالمحاضرة.
حبيبي
two
حبيبي.
words really, two words.
Thank you
And
for
I
your
think
compliment.
concerning the acute kidney injury critical care units. Honestly, just renal replacement therapy, do whatever you are familiar with. Secondly, do what your staff is familiar with. Do what's available to you.
Thank
Okay,
you.
these are really the three things that almost we see. Slow, hemodynamically unstable patient. If you don't have continuous renal replacement therapy, what's wrong really with intermittent, prolonged 6 hours, 8 hours? You can really achieve exactly more or less the same results. That's my view. Secondly, concerning the haphazard use of
Totally agree.
antibiotics. The haphazard abuse of antibiotics. It's really getting so bad, and we don't have any more drugs. Yesterday, we have a talk from our infectious disease guy about resistant antibiotic, bacterial resistance. It's really alarming. It's really alarming. And not only that, because use of colistin, as you mentioned, we don't like to use it. Tigecyclines and all these things really that start coming to the market. It's basically at one time we're not going to find any more antibiotics. So it's the abuse really. We have to be quite careful. Clinical pharmacologist, clinical pharmacist is a must in a critical care unit.
Thank you, Dr. Riyad.
Thank you for your
Professor.
comment.
أهلا well done سمير. إن شاء الله نراكم دائما على خير.
حبيبي دكتور رياض، ربنا يحفظك يا رب.
أهلا. Last comment from the CRRT is a procedure always left for nurses, and it is better for nephrologists that it is usually interrupted. Yes, I agree that CRRT is not continuous as usual. Usually it is interrupted, not that continuous. And if all dialysis procedures are nurse job mainly. Nurse job taking the upper hand. Nephrology just prescribing. I don't think in nephrology can is to spend the time all regarding all the time managing the machine, etc. Usually the nurse will take over her job regarding all dialysis procedures. Okay.
Thank you, Yasser. Thank you very much.
No more comments. No more questions. Thank you, Professor Samir. Thank you, my dear friend Samir, for this very, very interesting lecture.
Thank you.
Thank you for all professors who attended the session. Professor Saeed Khamis, Professor Riyad Saeed, Professor Hisham Al-Sayed. Thank you, my dear Mu'tasim Al-Sayed, for being the coordinator of this session. Thank you for this very interesting session, and meet you next time, Wednesday. إن شاء الله الأسبوع الجاي. Please remember 8:30 8:30 مش 9 زي ما الشتاء 8:30 عشان المواعيد تقدم من بدري شوية. Thank you. تصبحوا على خير والسلام عليكم ورحمة الله وبركاته.
عليكم السلام ورحمة الله وبركاته.
السلام ورحمة الله.